So I'll be focusing about what might be happening to the kidney in sepsis. Obviously, you've heard already that sepsis is the most common cause of acute kidney injury in the ICU. It's about 50% of what we normally see, and it carries a very high mortality if it is associated with the need of renal replacement therapy. There is no specific therapy for this condition, and it's only the treatment of sepsis that we focus on and supportive care. A major problem with our ability to develop specific therapies for the kidney is that we have a very limited understanding of the pathophysiology of septic acute kidney injury. And here I will focus on some aspects of it because it's incredibly complex. As many of you know, we spent the last close to 20 years using a sheep model, publishing about 50 papers to try to understand by using experimental models how sepsis might or might not cause kidney dysfunction. And as I presented before, the model is based on the administration intravenously of gram-negative bacteria, and then the animals are intensively monitored not only through macro hemodynamic monitoring, as would happen in human beings, but also through invasive renal monitoring. This is to give you an idea of what we don't see in our human beings, because this is happening either in the ward or at home, is the hemodynamic instability that occurs for the first 200 minutes or so, and then you have the animals settling into a pattern of hyperdynamic sepsis with the blood pressure falling and the cardiac output going up and the heart rate going up, as we often see, particularly in younger people presenting to the emergency department with sepsis. What people don't have, however, is the ability to measure renal blood flow as we do in the animal with transit time invasively placed and chronically embedded flow probes. And we can see that in these animals, when there is gram-negative bacteremia, there is an increase in renal blood flow, whether you give noradrenaline or whether you give placebo. And it's an increase that is sustained way out to 700 minutes, so way out to 12 hours, and it's unabated at that time. And of course, if you've got a low blood pressure and the renal blood flow has increased, you must have vasodilatation in the renal circulation, and that's what the physiologists call conductance. And indeed, conductance is increased and does not appear to be significantly altered by the administration of norepinephrine. So there is a mechanism of such vasodilatation that is not norepinephrine responsive. So in these models that we've reproduced and other people have reproduced with gram-negative administration, it appears that you have loss of renal function with oliguria and a rising serum creatinine and loss of creatinine clearance in the setting of renal hyperemia and vasodilatation. And I think that's important because many of you would have grown up with medical school teaching that all acute renal failure must be due to vasoconstriction, which is, of course, manifestly untrue, at least in the animals. So we came up with the possibility that for such dilatation to take place at the same time as there is loss of function, there must be afferent arteriolar vasodilatation. Otherwise, you couldn't possibly increase renal blood flow if the glomerulus is the terminus of the renal circulation. But if you don't also vasodilate the efferent arteriole, then you couldn't possibly have an increased renal blood flow because you have two gates controlling renal blood flow. But of course, if both of them dilated in the same way, when nothing would change inside the glomerulus, so you couldn't change the filtration pressure and you couldn't change the creatinine clearance and renal function. So there must be a greater efferent vasodilatation than the afferent vasodilatation for the filtration pressure to fall inside the glomerulus and for function to be lost. So we hypothesized that the decreased filtration pressure that is responsible for the loss of GFR might be due to such an imbalance of vasodilatation between the two controllers of flow into the glomerulus. We then hypothesized if that was true, that there was selective and greater efferent vasodilatation, then the administration of angiotensin II, which is a selective efferent arteriolar vasoconstrictor, should change this sort of functional loss. So we took animals and we randomized them to receive placebo or angiotensin II, and as you would expect, the blood pressure goes up with angiotensin II. The cardiac output is slightly altered, but not very much, and of course the total peripheral conductance is significantly diminished by the vasoconstricting effect of angiotensin II. As you would also expect, if you give angiotensin II, the renal blood flow dramatically falls, but please note it falls to levels that are similar to the levels that the animals were experiencing before sepsis. So you're restoring a degree of vasoconstrictive tone that is similar to the start of the experiment. Now, you might expect then that if you do that, the renal vascular conductance would diminish, and indeed you have renal vasoconstriction. And as you do that, what you see is that there is a significant increase, at least for the first 6 hours, in urinary output, and it's actually quite marked. So in the placebo animals, you go down from 80 mils to about 15 to 20 mils an hour with the onset of gram-negative sepsis. If you give angiotensin II in the first 6 hours, you're sitting at about 200 mils a minute. So it's quite a spectacular effect on urinary output, and it is also associated with an effect on creatinine clearance. So this provides in the animals, at least, that in experimental hyperdynamic sepsis, there is a loss of GFR that is lost in the presence of increased renal blood flow and renal vasodilatation, and this loss of function appears to be improved by the administration of angiotensin II, which causes renal efferent arteriolar vasoconstriction. So this is an experimental model. And obviously, like all experimental models, as a researcher, you're asking yourself, well, what's the relevance of this stuff to what we see in human beings all the time? Do we have any data about what might be happening to renal blood flow in human beings? And the data is very limited because measuring renal blood flow in human beings requires invasive techniques. One of them is the administration of para-aminohippurate and the measurement of its clearance by invasive sampling in the renal vein as well as in the urine. So you go back and try to find literature, and this is what we could find in 1973, the days before ethics committees stopped doctors from doing crazy stuff. And this is 11 patients with intra-abdominal sepsis where these measurements were made. And in these patients, the true renal plasma flow, which can be calculated for para-aminohippurate clearance, was elevated. And really not that different from what we see in the animals, about 50% above baseline. And it correlated nicely with cardiac output. That is, the higher the cardiac output, the greater the plasma flow in the kidney. And if you go back to the literature, you can go back to the 60s when people were given volunteers were given pyrogen, again, the days before ethics committees. And you can actually even go back to 1945 in another volunteer experiment showing the same thing. So it appears that at least from the very limited evidence that is available in man, the pattern of behavior of the renal circulation when it is measured is very similar to what we see in sheep. So we've got some human evidence, poor, but it's there. There's no contradictory human evidence. We got an experimental model of gram-negative sepsis, and they're all showing that there is hyperemia, but the increased blood flow is dissociated from function. So flow goes up and function goes down. So what the hell's going on? We've talked about the efferent arterial. Is it all efferent arterial vasodilatation? Is this the only explanation for this? Is this a model-dependent finding? What else can we do to try and understand this a little bit more? Well, we've got ethics committees. It was a bit of a struggle to get this through because it involved us taking patients with sepsis that were mechanically ventilated, intubated, and vasopressor drugs to the MRI machine, which is quite an undertaking. But we managed to do about 10 of them, and we used phase contrast measurement of renal blood flow, which is a technique used for cardiac MRI, which is highly accurate and allows us to get an estimate of renal blood flow in septic man. And when we did, we found that even in human beings, there was a relationship between the cardiac index and renal blood flow in this small cohort of patients, such as if your cardiac index was high, your renal blood flow tended to be high. There was a relationship between the systemic vascular resistance index and the renal vascular resistance index. So what's happening in the systemic circulation in these human beings appear to be mirrored in the renal circulation, which of course makes a lot of sense. And of course, the renal blood flow and the creatinine clearance were spectacularly dissociated in these patients. Again, confirming that when we looked at human beings, the findings were really not that different from what you were seeing in animals. And we try to understand this a little bit more. So we go back to the animals this time, and we get a little bit more invasive, and we insert probes into the cortex and the medulla to look at laser Doppler flowmetry-derived perfusion indices in the cortex and the medulla, as well as measuring oxygenation in the cortex and the medulla. So now we don't just have the renal blood flow, which of course you know goes up, and the renal vascular conductance, which goes up, but we got the ability to look at regional perfusion, measurements of renal perfusion, and local renal oxygenation. What you see is that the cortex perfusion is different from the medullary perfusion, so that in these animals, when you induce gram-negative bacteremia, despite the fact that the renal blood flow goes up, the medullary blood flow goes down. And despite the fact that the cortical oxygenation goes up, the medullary oxygenation goes down. So this is, to our knowledge, the first demonstration that there is a redistribution of blood flow and obviously consequent oxygenation during gram-negative bacteremia in animals that is consistent with what we would call shunting. And of course, in these animals, the creatinine was going up, the creatinine clearance was going down, the urinary output was going down. So these animals were developing functional renal failure very rapidly after a few hours of gram-negative bacteria administration, and they had evidence of intrarenal blood redistribution, otherwise known as shunting. So there is global blood flow, that's very nice, it looks like it's going up, but inside the kidney, there is medullary ischemia or medullary inadequate perfusion or decreased perfusion. So even if we invented this wonderful tool, a new device that allows us to measure global renal blood flow in septic patients, that may not tell us anything at all, because what we really need to do is to measure and assess the medulla in order to understand what might be happening to the distribution of blood flow. So then the next thing you're going to ask yourself, if this is happening, what is the basis? What is the anatomical basis for shunting? Because that's difficult to understand if you believe that the glomerulus is the end point of the renal circulation. Then you get obsessed with this and you go back and look at the literature, and in fact you find that beginning in 1897 and again in 1911, a doctor called Isaac and a German pathologist called Ludwig, and then again the French, using scanning electron microscopy, described anatomical pathways where the afferent arteriole, this is in the rat, where the afferent arteriole goes straight to the afferent vein. And there is a pathway for the venous system to be perfused directly without the flow going into the glomerulus and coming out the efferent arteriole. If this is true in man, and there is no data that it is true or untrue, then we have a pathway for shunting. And you wouldn't be that surprised, because shunting happens everywhere during sepsis. It would be extraordinary if the kidney was the only organ where it doesn't happen. Now, when you start looking at ways of being able to understand the medulla that might be applicable to human beings, we conducted experiments in these animals where not only were we measuring all of these characteristics of function, but also we had probes that were measuring medullary tissue PO2, and at the same time, an oximetry probe in the bladder of the sheep that was continuously measuring, just like the oximetric probe was measuring the medullary oxygenation, the oxygenation of the urine in the bladder. And the reason we did that is that we reasoned that the medulla is really the last bit that the urine sees, and so the oxygenation of the urine that leaves the medulla should be similar or in equilibrium to the oxygenation of the medulla. And given that the ureter is unlikely to have a great deal of metabolic activity, by the time the urine gets to the bladder, it should be very similar in oxygenation to the way that it was in the medulla, and therefore it might be a surrogate of medullary oxygenation. And when you look at the medullary tissue PO2 and you look at the urinary PO2, it looks like that might well be true. And when you do a correlation between urinary PO2 and medullary PO2, it's not that bad. And again, we were able to show that we have a correlation between the urinary O2 and changes instituted by the administration of vasoactive drugs. So it appears to be a sufficiently sensitive tool to pick up the changes that occur in medullary oxygenation with the administration of norepinephrine, and to be able to reflect them in the urine the way they occur in the medulla. And of course, they shouldn't come to a surprise. We're now conducting studies in human beings with sepsis where we're measuring continuous urinary O2 to look at what might be happening in the medulla. I'll just stop on this for about a couple of minutes. What about the tubules? There's been a lot of work looking at the histology in the literature. We've reviewed this ourselves. And when you look at what's known in animal models is that acute tubular necrosis is a very uncommon characteristic of the histology of experimental septic acute kidney injury. And there is apoptosis, but there is not much acute tubular necrosis. And most of the histopathological changes are non-specific with vacuolization, swelling, sloughing, and they're very, very bland, no matter what the model is and no matter what you look at. So is that also true in human beings? There is some data with rapid postmortem, again, that shows that the majority of patients have normal renal tubular cells on histology, and that histology is really bland. So again, the experimental data is reflected into the human data. More recently, in a very nice study that I think is probably the most accurate assessment of the histology in the setting of sepsis, we had sheep that were biopsied for 48 hours on a regular basis as they were developing septic acute kidney injury. And this is comparing the biopsy findings in normal animals versus that are mechanically ventilated and just kept there and biopsied in order to have a control population versus the animals that are in gram-negative bacteremia, and there's no evidence of difference in necrosis, basement membrane, mesangial expansion, podocytes, thrombotic microangiopathy, basement membranes, thinning, wherever you look, mesangial deposits, microvilli, etc., 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 etc. So the histology of animals exposed to 48 hours of gram-negative bacteremia is indistinguishable from the histology of animals exposed to mechanical ventilation and sitting there and having no other intervention except for being biopsied. So at least for the first 48 hours during experimental gram-negative sepsis, there is a dissociation, again, between function and structure. So global renal blood flow, in conclusion, may initially be high. And this is driven by decreased vascular resistance. What drives that remains unknown, but might include shunting and efferent arterial vasodilatation. Human data suggests that, again, flow and function are dissociated, and indeed, function, flow, and histology are all dissociated. And knowing about the macrocirculation may not be enough in any case because AKI may be a disease of the microcirculation. We now have preliminary data that continuous urinary O2 may provide us with a window on some of the changes that take place in medullary oxygenation. But of course, if these changes exist and if we can detect them, we have no idea how to manipulate them. Thank you very much.